his paper on comparison of the activity preservation of the BMP2 between extracorporeally irradiated and frozen autograft for biological reconstruction.
Good morning, ladies and gentlemen. It's my honor today to present here. Today, my topic is to compare the BMP function after ECIR and freezing autograft. We know for recycled autograft, we can either use ECIR or use freezing autograft. So in our previous study, we showed that both methods have identical clinical result. But when we do some image evaluation by ISO's radiographic form, we can find the freezing have a better result in osteoarticular in subchondral bone parameters. So we're wondering why freezing seems better than ECIR. So our hypothesis is maybe some proteins such as BMP preserve more function in freezing than ECIR. And then through SMAD pathway can have a better mesenchymal stem cell osteogenesis ability. So to prove that, we have 3 experiments. The first experiment, we take out the femur head from the femur neck fracture and send the bone for ECR treated for different doses. And also send for freezing for different duration. And then we check the BMP concentration by ELISA. The results show either ECIR or freezing have no effect on amount of BMP2 and also BMP7. So we still want to know how about the function of BMP. So in the second experiment, we treat the commercial BMP2 to different doses of ECIR and different timing of freezing. And after the incubation with a mesenchymal stem cell for 2 weeks, we check the SMAD concentration. And the Western blot results showed after BMP treated by ECIR, the phosphor SMAD in mesenchymal stem cell was decreased, and it is dose dependent. And after BMP treated by freezing, the phosphor SMAD in mesenchymal stem cells was also decreased, but it's no dose dependent. And when we compare the ECIR and freezing, we found ECIR beyond 5,000 rate have more adverse effect than freezing. Finally, we want to know how about the effect of osteogenesis. So we check the BMP-induced osteogenesis ability of mesenchymal stem cells. And the results show after BMP treated by ECIR, the osteogenesis ability of the mesenchymal stem cell was decreased, and it is dose dependent. And after BMP treated by freezing, the osteogenesis ability was also decreased, but it's no dose dependent. So again, when we found ECIR beyond 5,000 rate have more adverse effect than freezing. Discussion. So we know it takes 3 months for fracture union, but it takes 3 times longer for biological reconstruction for the bone incorporation. And we also has faced 10 to 14% non-union rate. In the past, we know some reason cause this problem, such as some adjacent soft tissue and vessel are damaged by the tumor or during the surgery, or the cell like osteocyte, osteoblast was killed after freezing or irradiation, or maybe due to the side effect of the adjuvant chemotherapy. And now we know some protein function may damage after freezing and irradiation. And the degree of BMP function damage was equal in freezing and ECIR 5,000 rate. But we know in ECIR, advanced protein damage will occur in higher irradiation dose. So here comes a question. Since we know 5,000 rate ECIR could preserve better protein function, so is it safe to apply 5,000 for ECIR? So according to several papers from 5,000 rate to 30,000 rate, demonstrate there's no tumor recurrence from irradiated autograft. So we believe 5,000 rate should be enough. And another question is, since BMP function was damaged during ECIR and freezing, so could we, and it's safe to add BMP during tumor surgery, will that cause tumor neogrowth? And according to several basic research show contrary conclusion, so the answer is still controversial. So our conclusion is freezing and ECIR have adverse effect on BMP function. And the 5,000 rate may enough for ECIR and can preserve more function. and add BMP during the surgery is still controversial. Thank you very much.
Thank you, Dr. Wu. Please be seated. Before we go on to the question and answer session, may I ask the speakers of the next 6 presentations to please be ready in the front line. The papers are now open for discussion for any questions from the audience.
Okay, so I'll ask a question to Dr. Kundavuda. Yeah. So did you see any dose-dependent relationship with the level of the vitamin D and the severity of the giant cell tumor, such as the size of the tumor or the stage of the tumor?
No, it was not dose-dependent in our study, but in the laboratory cultured cells, they have shown that it is dose-dependent. Rankle expression is there.
Manit, do you feel that your case group is kind of a bias, because considering the amount of vitamin D deficiency patients we have in the population in India, we don't seem to be we don't have an exact proportion of giant cell tumors occurring in those patients. So do you feel that this is kind of a biased number?
So we are aware of the endemicity of vitamin D deficiency, but through our study, we have proven that the giant cell tumor patients have a significantly lower vitamin D level as compared to the general low level of vitamin D in the population.
Hi, on the same topic, did you see any patients with giant cell tumor that had normal vitamin D levels?
Sorry?
Did you see any of the giant cell tumor patients? Did they have normal? Any of them have normal?
None of the patients had the normal. They were either insufficient or deficient levels.
So then I have a question for Dr. Wang. So I think that's a very wonderful study, but how do you see this work going? Do you see any druggable targets along this CEP55 pathway? Can we make it into a druggable target?
Maybe it's a future experiment, but now I just find that the overexpression in the OS cells. Okay, thank you.
There are no more questions from the audience. I would like to thank all the 5 speakers. I request you to please be seated in the audience. The next 5 speakers I'd like to request to come on stage: Dr. Vivek Ajit Singh, Dr. Song Hyun Kim, Dr. Lu Zi, Dr. Yoshihiro Araki, and Dr. Pratik Hegde. Vivek, yeah, that's the lectern for you. Vivek will be, yeah, sorry.